Topic number 10, bone fracture, dislocations, classification, clinical science and diagnostics. Lecture Shevchenko Alexander Romanovich, Baltic Federal University, Medical Institute, Kaliningrad, 2020. So, bone fracture is a medical condition in which there is a partial or complete break in the continuity of the bone. In more severe cases, the bone may be broken into several pieces. We have classification of fracture depending on first, mechanism of trauma, relationship to the environment, displacement, fracture pattern, fragmentation of the bones, and anatomical location of the fracture. Classification depending on the mechanism of trauma. First, traumatic fracture is a fracture due to sustained trauma. Example, gratia. Fractures caused by a fall, road traffic accident, fight, etc. Pathologic fracture, a fracture through a bone that has been made weak by some underlying disease, is called pathological fracture. Example, gratia. A fracture through a bone weakened by metastasis. Osteoporosis is the most common cause of pathological fractures. Periprosthetic fracture, a fracture at the point of mechanical weakness at the end of the implant. Here we see on the picture one type of the periprosthetic fracture, because we have here more dense structure inside the bone and bone crushed exactly on this side. Pathologic fracture. Here is the line of the fracture, and if you look at this part of the bone and this part of the bone, you can see that shadow of the bone is not so dense. So some pathologic process, maybe osteoporosis or bone metastasis, has weakened this part of the bone, so it can be fractured more easily. Relationship to the environment. Closed fractures are those in which the overlying skin is intact. Open fractures involve wounds that communicate with the fracture, or where fracture hematoma is exposed and may be thus exposed bone to contamination. If we say it in simple words, if we have ruptured skin, so this is open fracture. If overlying skin is intact, so it's closed fracture. Displacement. We have two major types of fractures due to displacement: non-displaced and displaced. On this picture we see displaced fracture. It can be translated or at latus with sideways displacement, like here, angulated, rotated, shortened, a reduction in overall bone length when displaced fracture fragments overlap. Fracture pattern. Linear fracture, a fracture that is parallel to the bone's long axis. We see it here. Transverse fracture, a fracture that is at a right angle to the bone long axis. Here, oblique fracture, a fracture that is diagonal to a bone long axis more than 30 degrees. And spiral fracture, a fracture where at least one part of the bone has been twisted. Compression fracture, wedge fracture, usually occurs in the vertebra, for example when the front portion of a vertebra in the spine collapses due to osteoporosis, a medical condition which causes bones to become brittle and susceptible to fracture with or without trauma. Impacted fracture, a fracture caused when the bone fragments are driven into each other and avulsion fracture, a fracture where a fragment of bone is separated from the main mass. So here we see avulsion, and here we see compression fracture, because body of the vertebra is spongy, and when people have trauma, fall from height, one of the vertebra can be smashed and look like this. And impacted fracture, when one part of the bone go to the another part of the bone. Fragmentation of the bones. We have incomplete fracture, complete fracture, and continued fracture. Incomplete fracture. A fracture in which the bone fragments still partially joined. In such cases there is a crack in the osseous tissue that does not completely transfer the width of the bone. Complete fracture. A fracture in which bone fragments separate completely, like on the pictures here. And comminuted fracture. A fracture in which the bone has broken into several pieces. We see it here too. And more easiest by anatomical location. At first, when we see the patient in the emergency room, we can say we have some injury or trauma in some anatomical location, and when we have X-ray or CT scan, we can say each bone exactly is broken now. We have two major groups of the signs of the fractures: absolute and relative signs. What does it mean? Absolute signs, this is the signs which occurs only in case of the fractures, bone fractures. And relative signs, it is the signs which can occur in case of the fractures, but in other conditions too. Relative signs of a fracture: it's pain, swelling, bruising, discolored skin around the affected area. The patient is unable to put weight on the injured area. The patient cannot move the affected area. The affected bone or joint may have a grating sensation, and bone crepitus. What does it mean, crepitus? It's easy to say. We can compare this sound with sound when somebody walking on the snow. It's crunchy sound. An absolute sign of a fracture: deformity and angulation, like we see in this photo. The affected area may be bent at an unusual angle, shortness of the limb, pathological mobility in the site of the fracture. If it is an open fracture and we can see the broken bone, this is absolute sign of the fracture. If we have some of these signs or all these signs, it's totally we can say that it is a bone fracture. When we make diagnosis when we make diagnosis of bone fracture, we must go by the schedule. And first of all, we must assess X-ray of the patient. So, first of all, we must read patient and image details. We must assess bone and joint alignment, joint spacing, cortical outline, bone texture, and soft tissues. On the 7th lecture, you will see all these points, but you must to remember, so it will be a quick recap of these points. Patient and image details. Start by checking you are looking at the correct image. The patient details should be checked and the date of time of the X-ray noted. The skeletal system is symmetrical, so it's particularly important to be sure you are looking at the correct side. You must start by checking you at the correct image, because it can be wrong patient. If you understand this is the patient which you need, it can be old photo, so you cannot see the pathology. So you must check the patient and the date of the image. Viewing principles. Confidence in assessing musculoskeletal system. X-ray comes from experience and the knowledge of normal appearances. All patients are different, so being sure of the distinction between normal and abnormal is often difficult. Here are some principles that may help you to determine if a finding is normal. 2 views are better than 1. Check all available images. If you have some old, always compare with old. Compare with the other side if it imaged on this photo. Scrutinize at least 2 views. In the context of trauma, at least 2 views of the body part in question are usually required if looking for specific disease entities. For example, erosions in rheumatoid arthritis. This may be less important in some cases, such as possible scaphoid injury. More than 2 images are required. Compare with the other side. Images of the asymptomatic contralateral side to a suspected abnormality are not routinely acquired for assessment of all bones and joints. If an old image of the contralateral side is available, or if the side is included as standard, for example, hip or pelvis, then comparison between symptomatic and asymptomatic appearances can be very helpful. Compare current with previous images. The old X-ray is said to be the cheapest test in radiology. If you are uncertain of an abnormality and there is an old image available of the area in question, then always look at it. Doing this often increases diagnostic confidence and can show progression of the pathology over time. If we look on this picture, we have on the current X-ray broken bone with the displacement, but if we look precisely on the old X-ray, we can understand this pathological fracture because density of the bone in this sector is lower than in other parts of the bone. Image quality. The acquisition of many X-ray images requires careful patient positioning, which may not be possible due to pain or reduced patient cooperation. High-quality images might not be achievable, in which case you will have to work with the images provided. If an image is suboptimal, you can ask the radiographer if there were particular technical reasons for this. Requesting a repeat image may be reasonable if clinically justified. Artifacts. Musculoskeletal system X-rays may demonstrate internal artifact, for example, due to previous orthopedic surgery or foreign bodies relating to an injury. If there is external artifact that obscures the area of anatomical interest, then if possible this should be removed. Bone and joint alignment. Loss of alignment may be due to a bone fracture or a joint dislocation. Both are associated with soft tissue injuries that may not be directly visualized. Joint spacing. Joint spacing may be narrowed due to cartilage loss or widened due to dislocation, dissociation. And most important, cortical outline. Careful scrutiny of the bone cortex is required because a check that is too brief will lead to incorrect or incomplete diagnosis. In the context of the trauma, the clinical features of a significant injury may be masked by other injuries. Remember to be systematic. If you spot one abnormality, do not stop until you are sure you have focused on all areas of the anatomy shown. Soft tissues. Scrutinizing the soft tissues can often provide helpful information. Not uncommonly, an abnormality of soft tissues is more obvious than a bone injury, or may even imply a bone injury that is not visible at all. And we go to the first aid to the patient with fractures. First of all, don't move the person, except if necessary to avoid further injury. Take this action immediately while waiting for medical help. So, if we have a victim of the car accident in the middle of the road, we must move this person, or we must block the passage of the transport. If we have bleeding, we must stop any bleeding. Apply pressure to the wound with a sterile bandage, clean clothes or a clean piece of clothing. If we have arterial bleeding, we must use a smart tourniquet, and we must use our hand to stop bleeding. We must press to the different anatomical side of the artery to stop its bleeding. We must immobilize the injured area. Don't try to realign the bone or push a bone that's sticking out back in. If you have been trained in how to splint and professional help isn't readily available, apply a splint to the area above and below the fracture sites. Bedding the splints can help reduce discomfort. Apply ice packs to limit swelling and help relieve pain. Don't apply ice directly to the skin. Rub the ice in a towel, piece of cloth, or some other material. Treat for shock. If person feels faint or is bleeding is in short, rapid breath, lay the person down with the head slightly lower, then the trunk, and if possible, elevate the legs. First of all, we must say, do we have some trouble in this situation? If something can injure you, and if you ask no, second step, you must call the ambulance, and then you must follow in these steps. Treatment of the bone fractures is a general approach, so we use it in the case of the operative and in the case of conservative treatment. First, wound care. Stop bleeding. We must make some sterile gauze on it. Pain management, non-opioid analgesics or opioids. Fracture care, conservative or surgical. Anatomic reduction, fixation and immobilization. If bone fracture is immobilized well, the patient doesn't feel any pain. Conservative fracture management. Indication: stable fractures, mainstay management of pediatric fractures. If you remember, pediatric fractures often have green stick fractures. Some part of the bone is splintered, but not all of the bone. Procedure. closed reduction, and, if necessary, mobilization of the fracture bone and adjacent joints with a cast or splint. The conservative treatment of the fractures involved repositioning of the bone fragments, wound closure if necessary, and application of a cast or splint to hold the bones in place. Immobilization facilitates the joining of the fragments and with it healing processes. Early mobilization should be achieved as soon as feasible to prevent stiffening of the joints. Further complication may be poor blood circulation due to dressing that are too tight or an increased risk of thrombosis and embolism caused by immobilization of lower extremities. Healing times depends on the location of the fracture, but the standard time period for custom mobilization is 6 weeks. It is important to bear in mind that an embolized limb can only carry limited weight, while full loading of a limb is possible soon after an operative treatment or osteosynthesis. Radiological controls should be performed regularly until the fracture is fully healed, since dislocation, example gratia caused by a fall, may occur during the healing process. Sufficient analgesia and early functional treatment should be provided. Orthopedic cast. Principle: immobilization of the fracture and adjacent joint. Pay attention to proper padding. Cast must fit snugly but not too tightly. Thrombosis prophylaxis after immobilization of lower extremities. Pain or discomfort after application of the cast might be a warning sign and should be taken seriously, as poor blood circulation may result in necrosis within a few hours. You must remember, a patient with a cast is always right. In case of doubt, remove and reapply the cast. Because if your patient say it's too tight or something, we have had the problem of blood circulation in this limb, or maybe a second displacement occurs when you apply the cast. So patient is always right in the type of cast applying. Surgical fracture management. Indication: unstable fracture, severe displacement, rotation deformities and displaced fragments, inadequate manual reduction and fixation. Procedure: anatomic reduction of the fracture and subsequent fixation and immobilization using: first, external fixation, immobilizing a fracture using pins or screws that are screwed outside of the skin, or internal fixation, immobilizing a fracture using implants, example gratia plates, screws, wires, and open reduction and internal fixation of the realignment of the ends of the fracture and stabilization of the fracture using implants, plates, screws, and wires. If we talk about internal fixation, we have break bone here, for example, and we can add some plate here, fix it, and our bone no more displacing. In case of severe trauma with dislocation of some bone fragments, we can use external apparatus, like the apparatus of the Ilizarov. With the needles, go through the bones and go externally, and it fixed these bone fragments into the place where it belongs. Complication of bone fracture. We have acute complication such as neurologic and vascular injury, bleeding, hematoma or seroma, compartment syndrome, and wound infection or osteomyelitis. Complication due to immobilization. thrombosis, pulmonary embolism, and infections. This is very often case of the patient death. So we must give the patient thrombosis prophylaxis in all cases of the trauma, but in the cases of the trauma of the lower limb, it's more needed, like in the cases of the upper limb. Long-term complications: avascular necrosis, complex regional pain syndrome, post-traumatic osteoarthritis, joint stiffness, contracture, joint instability, heterotopic ossification, in children growth disturbances after growth plate injury or Soter-Harris fracture, non-union, incomplete healing of a fracture with result in creation of a false joints, pseudoarthrosis. This is most often in the case of old patient. Clinical features, pain, swelling, limited weight bearing capacity and reduced range of motion, persisting after the normal duration of healing, usually 6 to 9 months. Treatment: debridement and resection, osteosynthesis, fixation, antibiotics in case of infected non-union. Here we see the case of severe osteomyelitis in the bone. Here we see pictures of the bone on the X-ray and on the autopsy. We see purulent contagions of the bone. And another pathology: joint dislocation. Joint dislocation is an abnormal separation of the bone and the joints with injury of capsule and ligaments of this joint. You can see that you didn't see this part of the definition in your textbooks, but you must understand what parts of the joint is blocked it from dislocation. And you must understand this is a capsule and ligaments. So in any case of joint dislocation, you have injury of capsule and ligaments of the joint. Symptoms of joint dislocations or signs of joint dislocations: intense pain, joint instability, deformity of the joint area, reduced muscle strength, bruising or redness of joint area, difficulty moving joint, and stiffness. You must understand we have used two humerus joint dislocation, and in this case patient didn't feel intense pain. He didn't feel any pain at all. But all these signs he felt. Diagnosis: initial evaluation of a suspected joint dislocation should begin with a thorough patient history, including mechanism of injury and physical examination. Special attention should be focused on the neurovascular exam both before and after reduction, as injury to these structures may occur during the injury or during the reduction process. Subsequent imaging studies are frequently obtained to assist with diagnosis. Standard plain radiographs, usually a minimum of 2 views, are completely enough to confirm the diagnosis. I give you just 10 seconds to think what is the dislocation in which joint occur. So I think everybody understands this is elbow joint because we see radial and ulna and humerus bone. Treatment. Once a diagnosis is confirmed, the joint is usually manipulated back into position. This can be a very painful process. Therefore, this is typically done either in the emergency department under sedation or in an operating room under general anesthetic. I must say, not always. You can see here this made under sedation or in the operating room under general anesthetic. Most of the cases doctors don't use any sedation or general anesthetic in case of joint dislocation treatment. But this is not right, because when you use sedation or general anesthetic and the muscles of the people is relaxing, so when you treat the person, he cannot have any more trauma. But then if you give treatment without sedation, he can have further trauma. And this is example of the treatment of the shoulder joint. This is another cases of treatment of the joints in the hip joint, and of course in the case of the shoulder joint too. Here you see, to relax the muscle, some weight put into the hand of the patient, and then the doctor put his foot into the armpit of the patient and pull the hand up and down. If you think this is very horrifying method of treatment, look at this picture. This is the picture that depicted the treatment of the spine bones displacement of the 16th century. So thank you for your attention. I hope you learned something new from this lecture. So see you in the next lecture.